Hi, everyone, and welcome to this short webinar on practical muscle ultrasound for neurologists. My name is Nens van Alfen. I'm a full professor of clinical neurophysiology at the Radboud University Medical Center in Nijmegen, the Netherlands. And muscle ultrasound is one of my main research focuses. So what are we going to talk about today? Well, first, a very quick credo of why I think people in neurology should learn how to use ultrasound as a diagnostic tool alongside your EMG and other diagnostic tools. And then I'm going to show you some examples of how you can look at a muscle and assess what's going on, and how to evaluate muscle ultrasound formally for diagnostic screening, but also for biomarker use. Remind you, this is a very brief presentation, so if you want more details, there's more formal training to be had, and I will show you where to get it at the end. And finally, we're going to take a look at muscle ultrasound and its use in neurogenic disorders such as ALS. So this is one of my favorite cartoonists, Gary Larson from the Far Side cartoon series, talking about a great moment in the evolution. And I think we as neurologists are sort of at the same point, right? We need to move forward with our diagnostics for the peripheral nervous system and muscle disorders. And we have a certain set of tools right now, some of which are quite invasive, such as needle EMG and biopsy needles. And I think using muscle imaging will make us do more with less discomfort to our patients. And the great thing is that it's all in your own hands as a neurologist. You don't need to send it to another specialty, or radiology or surgeon or whatever. So I think we should move ahead and fill our toolkit with something that's really useful to assess people with suspected NMD. And so let's look on a very practical example of how we would assess a muscle using ultrasound. So you see combined screen recording here. You may note, to turn the laser on, there's a very small pen stripe right there where we marked up this muscle at a standard length from the superior iliac spine to the kneecap. So we can make reproducible images using ultrasound. Now, when I start the video, we will put the probe on in a transverse direction. So you see the rectus femoris right there, vastus intermedius, and then the femur outline. And we make sure that we get the brightest image possible by tilting the probe until it's optimally bright. We redo this 3 times, and if we want to take quantitative measurements, we will combine and average them for all 3. And in this way, you can both visually assess and quantify this measurement if you like. Now, if you look at muscles, you may appreciate why the transverse slices are called starry night appearances. So this is a slab of meat. It's a picanha, tail end of a cow. And this is my gastroc. And you will see there's quite a striking similarity, right? You see the dark areas, both here and there. Those are the muscle fibers themselves. And you see the white stars in that dark sky, if you will. And those are the fascial linings right here. So this is what a normal muscle looks like in a transverse cut. And if you translate that a little bit further, so you're both looking in a transverse direction, you see muscle fibers, and longitudinally, you would see the ultrastructure. Well, it's sort of translate to the gross anatomy right here. So transverse, you have a beautiful anatomic feature. You see the starry night. You see underlying bone and cartilage layers that right there. Longitudinally, you get this beautiful image of muscle pennation angles and fiber direction, which makes it a little easier to assess, for example, muscle tear. Now, this slide sort of sums up how you should evaluate muscle ultrasound. So the basis of it is that normal muscle looks quite dark. Healthy muscle tissue is all like this. The night sky is almost the same as this subcutaneous layer right there. And only the fascial transitions will give you a reflection of the ultrasound and hence a white pixel on the screen. This does quite a bit of fascia and tibialis anterior, so there's lots of stars in this dark sky. But you can see what happens if people have a muscle dystrophy like this FSHD patient, facioscapulohumeral dystrophy, where there's a lot of transitions of the ultrasound from one tissue type to another. So from normal muscle to fat to fibrosis to fascia and back again. And a lot of transitions means a lot of reflections, means a lot of white dots on the screen. So you can see this muscle is very white, and the sound is caught in these upper layers and it doesn't get through. So there's less detail in the deep part. That is called attenuation. I think if you can see the difference between the two, you will do fine with muscle ultrasound. So basically evaluating it would give you these three options. You can just look at it and say, okay, I've seen this muscle before. I think it's either normal or abnormal, or I don't know. You can do a semi-quantitative analysis where you grade it on a visual grading scale. And I'm going to show you an example just now. And you can also fully quantify it using what's called grayscale analysis, where you draw this rectangle. It's a region of interest, and you have an image software create a histogram for black to white pixels and then show the average pixel value for it. This is beyond the topic of this talk, but this is the most, well, scientific way, if you wish. It does need reference values for your system, though. And this is the future, I guess. This is the AI version where you take a radiomics package and have that assess a muscle, but it needs to be trained. And therefore, we need a lot of data across centers. So this is the original HECMAT grading scale principle, devised in the 1980s, where a muscle would be graded along 3 axes, generating a 4-category scale. So you look at how dark is the muscle? Is it dark like subcutaneous tissue? Can I see that it's a muscle slice? Or basically, does it look like a slab of meat that has been cut? And can I see through it to the underlying bone? Now, in grade 1, all 3 conditions are met. So it's a normal-looking muscle, it's nice and dark, and you can see the bone pretty well. In grade 2, the muscle itself would have more fibrosis of fat, so it'll be slightly white, but you can still see through it and you can see it's muscle. But in grade 3, the architecture is getting disturbed and the bone is more difficult to see. And while in grade 4, it's a really white muscle. I mean, you can't even see it's the rectus femoris. I know where you are because the probe is there, but it's not apparent from the image anymore. And you can't see through it. Now, the unfortunate thing is that this scale, it sounds like it's a 1 to 4 grading in severity, but it's not. There is nothing linear about HECMAT grading like this. And so in reality, HECMAT grade 1 is usually a normal-looking muscle. HECMAT grade 2, if you score that, it's tossing a coin. It can be normal or abnormal. And that might depend on whether the person is old or has a high BMI. And HECMAT grade 3 and 4, as I've shown you, are usually abnormal, but in older people, it might still be within the normal range. So there is no linear correlation, which also means that you shouldn't calculate using this scale. It's categories. And the reason it's so non-linear is the reason why one of my colleagues, Stuart Wijntjes, in his PhD project, devised a new muscle grading scale that's more reproducible and more robust. And basically, it's simpler. So anyone can use this with high reproducibility. If you look at a muscle and you're used to your system, you simply say, this is normal, or I don't know, or this is an abnormal looking muscle. And you will, most of the time, be right. And now, over time, when you get more experience with looking at these muscles, you will put more images in the outer categories, right? So you're more certain whether it's normal or abnormal, and fewer images go into uncertain. And then you'll still be right. So this is a robust way of grading. And the uncertainty category is very important because sometimes you really just don't know, and you shouldn't assign some diagnostic significance to it. Besides the ultrasound echogenicity, so the brightness of the image, you can also look at patterns. So if you look on this left image here, this is rectus femoris again in the thigh, you see that it's diffusely white. Well, this is a very typical appearance of a dystrophic muscle, and this is a patient with FSHD again. Now, Duchenne might look the same. In the middle here, you see flexocarpi ulnaris in the ventral forearm, and this is the ulna, the bone shadow right here. And you can see that this FCU is half normal, half to white. And this is a very typical pattern for inflammatory myopathy, so myositis, which has these really patchy appearing areas of abnormality. And this matters, for example, if you want to do a biopsy, because you don't want to biopsy the normal part, it will end up giving you no diagnostic information in the histology section, right? You want to take this part of the muscle. So we pre-screen the biopsies that we do. We pre-screen the patient's muscles and select that part, which will give us the most information. And so here on the right, you see a very inhomogeneous pattern with these dark holes in the muscle surrounded by white fibrotic-looking tissue. The holes are actually remaining viable motor units. And this is a patient with long-standing neurogenic pathology, spinal muscular atrophy in this scenario. And it's called the moth-eaten or Swiss cheese appearance. So if I just give you this image, and you can see that it's taken from the ventral forearm on the ulnar side again, where this is the ulna, flexor carpi ulnaris, and these are the deep finger flexors, you might appreciate that this is a pattern that might be compatible with IBM, because there is a discrepancy in that disorder between the deep and the superficial finger flexors. And so it is in the correct clinical context. It's quite specific. So that's why it's also been advocated as part of the new supportive criteria for this diagnosis. If you think about visual grayscale analysis, it does imply that you know what muscles look like on your ultrasound system. And I can really recommend that you keep all settings standardized, because otherwise you will introduce variability during scanning. If you're accustomed to it and you have a little bit of experience, you will probably get to about 80% diagnostic sensitivity for normal or abnormal looking muscle. It doesn't mean that you know the diagnosis specifically, but at least you can say this patient needs to go on for further invasive testing. And that's how we use it in practice. Now, if you want to think about what protocol to use, it's really all yours to choose, like you would with electrodiagnostic testing, right? It's informed by the clinical scenarios. So currently at our center, we have diagnostic protocols for about 30 plus muscles, and the patient selection may vary from a simple muscle screen of 4 muscles in the body to a very large research protocol that would include 25 bilaterally. Some of these combinations have been created to match what we do in EMG, such as for ALS. Now, the one thing you do need to do here is standardize your image settings and really literally don't change anything, because even changing the depth setting on a machine will unpredictably change the gray level distribution. All these manufacturers of ultrasound machines, they make what's called proprietary software. They don't tell you what's going on the inside, so you can't predict the effect. So keep it stable. And then you also need to rigidly adhere to that 90-degree scan angle, because even a 5-degree angle change of the probe will give you a much darker image. So here's just some examples. I'm not going to go through them in detail, but this would be the protocol for a very simple unilateral neuromuscular disease screening. And this in kids already has about 90% diagnostic accuracy. Very simple screen using these muscles. These are the protocols for you to review. You can see we always select the muscle at the site of the maximum bulk. That's sort of the rule, which makes it most reproducible as well. If we go to a more extensive screening protocol, for example, in adult neuromuscular disease, we would do this bilateral protocol of the limb muscles, both proximal and distal, and include other muscles like trapezius, gastroc, deltoid, vastus lateralis, also at their standardized positions of maximum bulk. For polyneuropathy, you might want to include a few more distal muscles like this peroneus tertius or the FDI. And so I've outlined a couple of them here. You can also screen facial muscles. And for example, depressor anguli oris is one that's nice and reproducible. And then finally, the largest protocol in general practice would be motor neuron disease screening, or for ALS, where you have the 4 body regions. You include things like trapezius, masseter, sternocleidomastoid, abdominal muscles as well. And so here they are also standardized in their measurements. Now, nowadays, if you don't have the big machine in your department, there's these handhelds on the market like this one. This is a linear 15 megahertz probe. And things like these, they just cast their image to your phone or an iPad or something. They are very handy just to put in your pocket. This is actually the battery part. This is the scanner. And if this boy would come into your office, who obviously has a Gowers maneuver, and he might also have a slightly hypertrophic calves, a very simple screen would show these muscles. And for example, this gastroc is definitely abnormal. So even by a 5-minute screen, you would know that this boy needs to go on for further testing. And in his scenario, I would think I would do genetic testing for dystrophinopathies first to see if he has Duchenne, right? So this visual evaluation, in a sense, works, but you could do better because sometimes visual evaluation is difficult because echogenicity, for example, increases with age. And this is a very young person, 5-year-old, nice and dark muscles, same as the subcutis. But if you're 49 like this, everything is slightly more hyperechoic with the same image setting, and it's still normal for that age. And if you're 75, you can see that this muscle is really whiter than the subcutaneous layer. So that would be one of those HECMAT grade 2 gradings, but in this scenario, it's just an age effect and it's still within normal limits. Same thing goes for BMI. So this is a person with a normal BMI, 22, and you can see the muscle here. But if you go to a BMI of 38.2, like this person, so this is skin, subcutaneous layer, and this is rectus, you can see that people who have high body mass index also stack fat in their muscles, right? So the muscle also becomes brighter. And for this BMI, that is still within normal range. It doesn't indicate a neuromuscular pathology. And now there's a third thing that is especially relevant if you look at regions of your body where there's more muscle groups, is that our eyes are very contrast sensitive. So for example, this is the forearm flexor region, and this is flexor carpi radialis, palmaris longus right there. These are the deep flexors. And you can see that FCR, it's much darker here than the deep flexor region. But that doesn't mean that this muscle is normal. And it's sort of a similar effect as this rectangle right there is equally gray all over. It's the same shade, but because this is in a dark area, it looks bright. And because this is in a bright area, it looks dark. And our eyes cannot unsee it. And so by visual evaluation, your eyes and brain will suffer from this effect when assessing this, because basically this muscle is abnormal. So it helps to quantify your images by using that histogram gray level analysis we talked about a little bit earlier. It's a whole technique in itself. If you're interested in doing things like that, please just shout out and send me an email or something, or reach out via LinkedIn. But if you do that, you can see that the gray values that you get are very steeply correlated, for example, with Duchenne patients while they age. And age here is a proxy for disease progression, right, in these boys. And they are also very steeply negatively correlated with their childhood myositis assessment scale, which is a functional scale. So in classic neuromuscular disease, quantifying echogenicity makes your assessment more sensitive, but also more predictive, if you will. And the same goes for FSHD. We have an expert center for these disorders, and we have seen in several longitudinal studies that over a 5 to 10 year time span, clinical outcome as a group doesn't change really. And visual image analysis, whether it's ultrasound or MRI, doesn't show any visible changes either at the group level. But quantitative analysis for both these imaging techniques does. So this is actually the quantitative image analysis with ultrasound or MRI is the most sensitive technique to track these patients over time, and also to see the effect of a treatment. So this is sort of the very short summary of that, if you want to use ultrasound or even MRI as a biomarker. Now, ultrasound is different from MRI in the sense that if a muscle dystrophy would progress from normal muscle histology to completely fatty degenerated muscle, The MRI fat fraction, if you can imagine, will increase until the whole muscle is fat. So the fat fraction is maximum. But at some point, the ultrasound echogenicity score will go down again because fat, all fat, is dark. And so it's a parabolic relation, not a linear one. And you need to take that into account if you want to calculate with numbers in this scenario. So here's an example showing that. This is an advanced dystrophy patient with a fully fatty degenerated medial gastroc right there. And the ultrasound actually looks within normal range and similar to the subcutaneous tissue, only there's no muscle texture anymore. So this is all fat, and that sort of looks normal. So this is a very busy one of those AI-generated overviews of a summary how to assess muscle ultrasound, right? So you can do the qualitative visual analysis, simply eyeballing a muscle with one of those handheld scanners, just at the bedside, use your clinical info and use the ultrasound as an extension of your hands and your physical exam. And this will be observer dependent, as will your physical exam, right? Strength testing or the tendon hammer. But you don't need any additional tools, and it's very patient-friendly, right? If you want to make it a little more formal, use that 3-tier grading, like, okay, I think it's normal, I don't know, I think it's abnormal, and you will make your assessment a little more robust. And if you really want to go all the way, use objective numeric references, measurements, fat fractions, ultrasound echogenicity scores. But then you will need reference values for your machine and your settings. You may need integration with AI tools or other digital infrastructure. So this usually is interesting if you're a neuromuscular specialist center. If you just want to assess a muscle now and again during your EMG to make sure that you stick the needle in the right spot, I would suggest you use either of these techniques. Now, and finally, a few words about ultrasound as an alternative to assessing denervation. So sometimes you have patients who do not tolerate electrodiagnostic testing, either current on their skin or needles in their muscles. So you could use ultrasound like this. This is a patient with a suspected radiculopathy, but this person was a refugee from a Middle Eastern country where they were tortured with electric stimulation and they refused to undergo. So we made this ultrasound image of the left calf, which was asymptomatic, and you see normal-looking muscle tissue for the medial lateral gastrocs and the soleus. And then we scanned the other side, and you can see that now medial gastroc, which is on this side, is very abnormal. Lateral gastroc is also not okay, but not as fibrotic as this one. And you can't really see here. So something's going on in this calf. Okay, it's the symptomatic side. And it's more in the S1, S2 component than in L5, S1. So you know that this is confirmatory of a specific type of pathology, right? And then if they allow you to stick a needle in, you just stick that in one muscle and not just blindly assess them all. And so here's the corresponding anatomy for this slide. This is a similar type example. This is a young girl who fell from a climber and broke her arm. And she also had difficulty moving her fingers, and she had paresthesia in that arm, so traumatic injury. And then a very simple screen of the unaffected side shows normal bone, normal muscle groups. And the affected side shows hyperechogenic muscles, both in the median and in the ulnar nerve distribution. So this taught us that we also had to look at the nerves with ultrasound, which is something else that we do, and that is excellent for assessing traumatic injury. And so we don't need to stick a needle in because she will tell us how well she can use the arm, like strength testing and functionality. And then the ultrasound gives you the distribution pattern, and the nerve ultrasound gives you the nerve type injury and whether you should operate or not. So then you don't need the EMG at this point at all. Now, one of the great things about muscle ultrasound is that it's dynamic. And if I start the video, you can see these twitches, jerky little movements in this biceps and brachialis muscle. Those are fasciculations. And as this is a pickup area of a 5 by 4 centimeter screen, you can imagine that you see a lot more like this than you would with just the tip of your EMG needle. So it's actually, and that's been proven over and over again, the most sensitive technique to look at fasciculation right now. And you don't need reference values. You don't even need to standardize that much. You can just look at the screen. And so it's been shown a couple times now over the years that it's not the echogenicity changes per se, but the fasciculation and their counts that makes your ultrasound a very good diagnostic tool to augment your diagnosis for ALS. So just using ultrasound to detect fasciculation will give you about 30% more fascics, increasing their identification to almost maximum. And if you have the appropriate clinical context and you screen 9 muscles with ultrasound and you find fasciculation in more than 3, that gives you very high diagnostic values for this patient having ALS. While if you would only look at the gray levels, so how white the image is, the diagnostic utility would be much lower, like 50%. And so there's a simple 5 muscle screening protocol to do this, which makes use of the different body regions. And you can already discriminate ALS from relevant mimics like radiculopathy or IBM with very high certainty, 94% accuracy. And I think the real value here is not to use one or the other tool, but it's to have them both, because if people come to you with a question, doctor, do I have ALS? They want to be sure as you possibly can. And that is what the ultrasound gives you. If you add it to EMG or vice versa, 25% more patients will have a more certain diagnosis. That's where the real value lies. So to summarize, muscle ultrasound in your practice, just use a strict protocol and setting always. Make a preset, fix it, don't touch it. Make a depth preset as well. For example, 4 centimeters for the limbs, 6 centimeters for the thigh and abdomen, and just use that. Always visually evaluate your images for quality, but also assess whether you think they're normal, uncertain, or I don't know. If you have time and interest, you can add quantification using a histogram tool. And even without a reference value, you could compare this patient to themselves over time, right? Like the next time you're going to see them. If you can, add a reference measure and calculate z-scores, so the number of standard deviations your gray levels are above the mean. But I would say, even if you don't have a big neuromuscular clinic and you have one of those handheld tools, just use it, because it's such a convenient and powerful little tool, an extension of your physical exam in your pocket. And it's really proven at this point that it will help. So just do this. So thank you very much. And if you want to know more, I could heartily invite you to join our special interest group. So the IFCN is the overarching structure of neurophysiology societies. And there's several special interest groups in them. And one of them is the IFCN Society of Neuromuscular Imaging. And we put out newsletters with training opportunities, new guidelines. There's a new neuromuscular ultrasound curriculum that has just been approved by the board. So you don't need to reinvent the wheel. You will find colleagues there who you can reach out to and who can help you. I hope this has been useful for you, and I look forward to the Q&A. Thank you.